So, you're nearing the completion of your training and have, in the parlance of the ACGME, demonstrated sufficient competence to enter practice without supervision. But unless you're one of the few graduating residents who is going into solo private practice, you won't be working independently, but instead you'll be working with or for an organization or other individuals. You've found what you think is the ideal job. Ensuring that your job is what you think it will be is a purpose of your contract. At the same time, your contract details what your employer or partners will expect of you. In this introduction to physician contracting, we'll go through the basic elements of a physician contract and common metrics pertaining to each section of a physician contract. We'll discuss work RVUs, which are commonly used as a measure of clinical productivity, and also discuss quality measures, which increasingly factor into incentive plans. We'll also discuss additional compensation considerations, discuss some contract aspects specific to entering into private, but not solo practice, and finally discuss some miscellaneous topics pertaining to physician contracts. There are 4 basic elements found in most physician contracts: the offer letter, an employment agreement, a statement of specific clinical productivity requirements, and a statement pertaining to whatever incentive plan may be in effect. The first element of the physician contract is the offer letter. As its name suggests, it details what you are being offered, or in other words, what you will get as a result of your job negotiations. There are several usual components. The letter includes an initial commitment to you to be part of the physician group or organization, as well as the term or duration of employment. The initial term is usually at least a few years, although contract renewals after the initial term may be for 1 year. The offer letter includes the annual base salary. If the term of employment is for more than 1 year, the base salary for each year is specified. It may be fixed or may incrementally increase. If your job is with a university, the offer letter will indicate whether you are in the tenure stream or non-tenure stream. However, the specifics of advancement within either the tenure or non-tenure stream are determined by your institution. The offer letter will specify the allocation of your time among clinical, research, teaching, administrative, and other activities and duties. This may be expressed in terms of percentage of time, days per week, or weeks per month or year. If your clinical activities occur at more than one hospital, for example, at a university hospital and at a VA hospital, the distribution of time among the hospitals may be specified. The offer letter will state whether you are included in an incentive plan. As we will discuss in a few minutes, if you are included in an incentive plan, the details of your participation will be provided, often as an additional exhibit or attachment to your contract. The offer letter will include administrative titles that are part of your hiring, such as section or division chief or associate program director of the surgery residency program. Finally, the offer letter will include resources that you may have negotiated. These may include research monies or personnel, administrative assistants, or in other words, secretaries, mid-level providers, and surgery schedulers. The employment agreement is your contract. Written in legal terms, it specifies the terms and conditions of your employment. Important among these are termination conditions, both for termination initiated by you or by your employer. The employment agreement also invariably includes a non-compete clause that specifies both a geographic range as well as the duration of the non-compete provision. The employment agreement also includes requirements pertaining to compliance and adherence to government and hospital regulations, such as Medicare regulations, accurate billing, and Stark law limitations on patient referrals. The third section of the physician contract specifies your clinical duties and requirements. Many of the items in this section are repeated from the offer letter. Elements of this section typically include a minimum number of clinical hours per week and clinical weeks per year. These numbers may be reduced based upon how your time is allocated between clinical and other duties. This section may also include call responsibilities and hospital assignments, as well as minimum productivity requirements. Productivity may be based upon charges or collections, especially in private practice. In larger organizations, productivity is frequently based upon work RVUs, which we'll return to in a few moments. Once again, clinical productivity minimums will be reduced according to your percentage of clinical time. There may be additional requirements such as attendance at departmental meetings, teaching duties, and adherence to compliance requirements. So what is a relative value unit? As work RVUs are a common measure of clinical productivity and figure into many clinical incentive plans, it's important for you to have an understanding of RVUs. Using a common scale, Medicare ranks the resources used to provide each physician service. For each service, Medicare determines RVUs for three types of resources. These resources are the physician's work, the expense of the physician's practice, and professional liability insurance. Physician work RVUs account for the time, technical skill and effort, mental effort and judgment, and stress to provide a service. This is the portion that's relevant to physicians. Practice expense RVUs account for the non-physician clinical and non-clinical labor of the practice, as well as expenses for building spaces, equipment, and office supplies. Professional liability insurance RVUs account for the cost of malpractice insurance premiums. Medicare calculates a payment that factors in each of the three RVU categories, as well as a factor that accounts for variation in cost of practicing medicine in different locales. This is the Geographic Practice Cost Index, or GPCI. There is also a conversion factor, or CF, that Congress determines in its budgetary process. The payment is shown here in this equation. Physician work RVUs and practice expense RVUs account for approximately 52% and 44% respectively of Medicare's payment. CMS publishes a work RVU table that is periodically updated. The link for this table is shown here. Some work RVUs for common general surgery procedures are also shown here. In addition to your base salary, your employment may include participation in an incentive plan. If you are participating in an incentive plan, your contract will include an additional exhibit or attachment pertaining to the incentive plan. The incentive plan provides you with additional compensation based upon productivity. How your compensation is split between base salary and incentive may vary. Generally, your base salary can be thought of as guaranteed, provided that you meet the requirements laid out in your employment agreement and clinical requirements. The incentive portion of your compensation may be substantial but is not guaranteed inasmuch as it is tied to your productivity. In some cases, participation in the incentive plan is delayed for a few years, during which you receive a specified salary. This allows you time to develop a clinical practice and achieve the levels of productivity needed to benefit from the incentive plan. Once you reach such levels and begin participation in the incentive plan, your base salary may remain the same or increase, but it might also decrease with the expectation that your incentive payment will offset and exceed any decrease in your base salary. In addition to whether and when you participate in the incentive plan, there are three other important details regarding the incentive plan: the metrics used to determine your productivity, the manner in which the productivity earnings are distributed, and any modifiers that impact upon incentive compensation. Most plans emphasize clinical productivity, and most measure productivity in terms of work RVUs generated. Commonly, a certain dollar value is given to work RVUs generated above a certain threshold. The threshold may be decreased if you have significant non-clinical duties, especially if these are revenue-generating duties or administrative duties that are critical to your organization's mission. Consider the following scenario. The threshold for your organization's incentive plan is 8,000 work RVUs per year. However, you are the residency program director and 50% of your time is allocated to this role. Accordingly, your threshold for the incentive plan is reduced by 50%, so any work RVUs in excess of 4,000 contribute to the incentive program. Work RVU credit may also be given for certain activities that are critical to the organization's mission, such as academic productivity or teaching. For example, an RVU value may be attached to each published paper, for national presentations, for medical school course directorship, or for leadership positions in national organizations. Smaller practices, especially private practices, may determine incentives based upon actual revenues generated and collected. Next is the matter of how the incentive monies earned are distributed. There are three basic models. With the individual model, each person receives the incentive revenues that he or she has earned. In contrast, with the group or pooled model, the incentive revenues earned by all members of a group are pooled together and then distributed among the members of the group. The group may be the entire organization, such as the entire Department of Surgery or the entire private practice group, or a subset, such as a specific division or service. There may also be criteria for inclusion in the distribution of the incentive earnings. For example, distribution may be limited to those individuals who actually contributed to the pool. A group incentive plan may be used to encourage collaboration and diminish competition within the group. Assigning values to other contributions, such as academic productivity, recognizes non-clinical contributions of members of the group. Group or pooled models that share the pooled earnings equally among all members of the group will tend to redistribute incentive earnings from high producers to low producers. A hybrid model blends individual and group components and reduces this redistribution. For example, 75% of an individual's incentive earnings might be paid to the individual, while the remaining 25% is pooled with other group members' contributions and then redistributed. Such hybrid models are intended to encourage both individual productivity and group collaboration. A few more comments about incentive plans. Incentive plans may place caps on incentive earnings. However, as such caps discourage productivity, they are uncommon or tend to be set at levels that are infrequently reached. Incentive plans may also include provisions to encourage desirable behaviors. Quality-related measures rank highly on the list of such behaviors, as they are thought to correlate with better patient outcomes and are looked upon very favorably by the general public, Medicare, and other health-related entities. Examples include adherence to skip measures, low surgical complication and infection rates, and low readmission rates. Failure to meet thresholds for such measures may result in a reduced incentive payment. Failure to meet requirements, such as those listed in your clinical requirements, may also lead to a decreased incentive payment. The federal government and Medicare have been concerned about fraudulent billing for physician services. This has led to establishment of compliance programs to help physicians avoid fraudulent activities and to ensure that they are submitting true and accurate claims. It's likely that your organization has such a compliance program, as fraudulent billing can lead to suspension from the Medicare program. One component of such compliance programs is internal monitoring and auditing, with which a physician's charges are reviewed for accuracy. Failure to meet a specified accuracy rate may lead to requirements for further training in coding and ultimately lead to penalties such as a decreased incentive payment. You may be eligible to receive compensation for a few other reasons. As we noted earlier, the percentage of your clinical time may be reduced because of your administrative responsibilities, and with this, your work RVU incentive threshold may be decreased. Alternatively, instead of a reduction in clinical time, you may receive supplemental pay for your administrative duties. You may also be eligible for a sign-on bonus or compensation for your moving and relocation expenses. These might include travel expenses for your family, house hunting expenses, temporary housing expenses, and moving and storage expenses. For the next few minutes, we'll discuss some contract considerations pertaining to private practice. Most contract considerations for private practice are the same as for academic practice, but a few differences deserve specific comment. First, what's your status within the practice? Are you a partner or an employee? And if you're an employee, are you in a track that leads to partnership? If you are an employee, most of our prior discussion applies to you. If you're in a partnership track, what is the timeline to partnership, and are there criteria for partnership other than years in the practice? Our earlier discussions focused on compensation. If you're working for a large organization, your employer factors in expenses when determining base salaries and structuring an incentive plan. Your expenses add to the organization's expenses, and therefore ultimately they do impact on your compensation, but in a manner that's much less immediate and much less obvious on a day-to-day basis. As a result, your focus tends to be primarily on your compensation and not on your expenses. In contrast, if you're a partner in a private practice, especially a private practice with only a few partners, the expenses of the practice are your expenses and have a very clear impact on your compensation. The net revenues for the practice, and therefore the funds available for distribution to you and other partners in the practice, depend upon both the income generated as well as the practice expenses. So it's important to understand not only how income generated is distributed, but also how expenses are allocated. Compensation models for private practice can range from a solo practice model to a group model. With a solo practice model, an individual's compensation equals his revenues generated minus his expenses. With a group model, revenues are pooled, total expenses are subtracted, and the remainder is divided among the partners. As in our earlier discussion of incentive plans, hybrid or blended models also exist. For example, revenues may be pooled, and then after all expenses have been paid, the remaining revenues may be distributed according to individual productivity. A common variant of this model is to provide each individual with a base salary and then to distribute the remaining revenues according to individual productivity. Work RVUs, charges, or receipts may be used to measure productivity. Receipts reflect the actual revenue collected by the practice, while work RVUs and charges have the advantage of reflecting an individual's work, especially as payer mix and reimbursement rates can vary widely. If expenses are not divided equally, assignment of expenses to specific individuals may be more difficult. While certain expenses, such as malpractice premiums, can be easily attributed to a specific individual, other expenses, such as salaries for office personnel, may be harder to assign. Some practices assign the cost of such shared expenses based upon clinical productivity, with the rationale being that the busier physician uses more resources. As with our prior discussion of incentive plans, the practice may also decide to reward certain behaviors. For example, high patient satisfaction scores and cost containment measures may be rewarded. Whatever plan is chosen, it is important that it be easily and accurately implemented, transparent, and agreed upon by all partners. When it comes time for you to become a partner or owner in a practice, it is likely that you will be required to buy your share of the practice. The terms of this buy-in may be specified in your original employment agreement with the practice, or it may be negotiated when you become eligible to become a partner. The central consideration of the buy-in process is the valuation of the practice. Three factors primarily determine the value of the practice: tangible assets, accounts receivable, and goodwill. Tangible assets include cash, furniture, equipment, and other items with measurable cash value. Accounts receivable are monies owed to the practice for services already provided by your future partners. Goodwill is the value of the practice's expected future earning power. Tangible assets and accounts receivable can be easily determined, but goodwill is an intangible asset and harder to determine. Put another way, goodwill is the difference between what you are paying to join the practice and the net assets of the practice. Some practices consider only tangible assets and accounts receivable when determining the buy-in cost for a new partner. Others factor in goodwill, but there are no reliable, well-established methods for determining goodwill. Consulting firms may offer an opinion as to the goodwill value, or comparisons can be made to similar practices. Once the buy-in amount has been determined, a payment schedule is determined. An immediate one-time lump sum payment may be required, or the payment may be spread out over several years. Here is a link to a reference used for this discussion. It contains a great deal of useful information. Here are a few additional miscellaneous considerations pertaining to your contract. As you are negotiating for your job, this is your best opportunity to ask for resources and various types of other support than your personal compensation. This may include research support, secretarial support, or support for specific clinical or academic programs. You should confirm the benefits that your job will provide. Commonly, you will be offered a retirement plan, but the vesting period for the retirement plan, if any, may vary. You will also likely be provided with, or at least offered, health, life, and disability insurance. Your disability insurance should be as job-specific as possible. As a surgeon, you would like your disability insurance to take effect if you are unable to operate, regardless of whether you're able to perform other duties as physician. You'd also like to have as short a qualification period as possible. It's important that you be aware of important dates. These include your work start date and the beginning and end of your contract. You should also be aware of the productivity and quality performance periods that are relevant to your incentive plan. It's also very important that you're aware of and adhere to the dates and deadlines pertinent to your job. If you do not get your license or submit your credentialing or insurance enrollment information on time, you may not be able to start working on time, or worse, your hiring may be jeopardized. Two last comments. Be sure that whatever you have agreed upon during your negotiations is written into your contract. If it isn't on paper, it doesn't exist. Finally, get expert help to review your contract. You're a surgeon, not an attorney. Find one who specializes in employment contracts, and in particular one who specializes in physician employment contracts.